Jain.
Good morning, doctors. Welcome to another podcast on CGHS Clinic. Today's speaker is a multifaceted personality. She is champion in rifle shooting, a qualified dancer in Kathak, and she is known in her wellness clinic for her clinical acumen and administrative skill. She is an experienced homeopathy physician from Bangalore, Dr. Shivangi Jain. She is going to speak on diagnosis of atrial fibrillation. Please welcome Dr. Shivangi Jain.
A very warm greetings to all my respected colleagues. Before beginning, I want to earnestly thank Dr. Dhadke to have given me this opportunity. Today, we will talk about atrial fibrillation, its identification in WCs, and how to work up a case once diagnosed. Let us first understand what is atrial fibrillation. Atrial fibrillation is the most common type of supraventricular tachycardia frequently seen in clinical settings and is characterized by uncoordinated and uncontrolled atrial contractions. This leads to numerous tissue islets in various stages of excitation and recovery, reducing the effectiveness of both atrial systole and diastole. On ECG, this chaotic activity is seen as irregular rugged baseline. Sometimes the baseline may not record this activity and may look flat. Only some of these irregular unsynchronized stimuli are transmitted via AV node, causing irregular but normal looking QRS complexes, unless there is any other block or ventricular pathology, which would be recorded as white QRS complexes. The atrial rate in AF could be up to 600, while the ventricular rate could be somewhere between 110 and 150. But it's not uncommon to find normal heart rates in atrial fibrillation. On echocardiography, we all know that atrial fibrillation is classically described as a bag of worm. Coming to the risk factors, old age has been found to have a high correlation with atrial fibrillation. Over 9% of the geriatric group over age of 80 years could be having atrial fibrillation. Other coexisting cardiac diseases, thyroid diseases, and acute febrile illnesses, electrolyte imbalance, or infections are also known to increase the risk of developing atrial fibrillation. AF could be both symptomatic or asymptomatic. The fact that a large number of patients could be asymptomatic should always be kept in mind, for it is like the silence of the lambs. Symptomatic presentations could be as fatigue, which is due to reduced cardiac output consequent to AF, or shortness of breath, again attributed to the same along with a possible cardiac failure, palpitation or awareness of heart beating against chest. At this point, it would be worthwhile to understand that AF may reduce ejection fraction to as low as 10% by compromising atrium-assisted filling of ventricles. A reduced cardiac output causes dizziness, lightheadedness, and maybe even syncope, about which we have been beautifully briefed in one of our earlier lectures. Reduced CO could cause angina, which may even precipitate cardiac ischemia. AF also provides a fertile ground for thrombus formation in atria, consequent to the blood stasis, causing thromboembolic complications such as stroke. These above presentations could range from mild to severe ones, or could be either transient or persistent in nature. However, it is the asymptomatic patient that we are likely to receive in our WCs. These patients may not have experienced anything abnormal or could have had milder episodes of the earlier mentioned symptoms. A casual hand on the pulse revealing its irregularly irregular nature or a routine ECG could be the way of AF revealing to us in a person. It is to be noted that even in patients with known atrial fibrillation, up to 75% of the episodes are asymptomatic. Comparing the two groups, asymptomatic patients have a higher rate of CVA as compared to symptomatic group, as the latter is likely to seek help. They are also reported to have a lower incidence of CAD as opposed to symptomatic group. However, there isn't a significant difference in mortality among the two groups. Cognitive decline is another way in which AF could be presenting to us, which is due to microischemias over a period of time from thromboembolic phenomena originating in atrias under fibrillation. Once a clinical suspicion of AF has aroused or a confirmation has been made, the first step is to assess the hemodynamic stability of the patient. Patients complaining of ongoing angina or developing stroke, or presenting with pedal edema, distended jugulars, or pulmonary edema, which are hallmark signs of CCF, should be immediately shifted to a proper facility for management. Those who are hemodynamically stable should be further assessed at our WCs. A detailed history at this point is warranted, including duration of symptoms, triggering factors, other illnesses such as cardiac diseases, thyroid status, medications, any childhood history of recurrent infections or illnesses, etc., and a complete physical examination. In those patients who are symptomatic, identifying and addressing the triggering factors can reduce anxiety, build up a strong doctor-patient relationship, helps in reducing frequency of the attacks, and lowers the risk factor for stroke. The triggering factors could be exercise, infections, coffee, alcohol, exertion, dehydration, or loss of sleep. Depending on the length of episode or duration, AF can be transient, persistent, long-standing, permanent, or lone AF. Any episode lasting less than 48 hours, which usually self-aborts, is paroxysmal and transient in nature, and is precipitated by any triggering factor as discussed earlier, is transient AF. Episodes lasting longer than 48 hours and are not reverting on their own are known as persistent AF. Atrial fibrillation lasting longer than 1 year could be either termed long-standing if it has been decided to treat them, or permanent AF if it has been accepted as a long-term rhythm for the patient. AF happening in patients with no structural cardiac diseases or who are younger than 60 years are termed lone AF and could be benign in nature. However, a complete examination should be done to rule out any other cause. Coming to the causes of AF, they could be either cardiac or non-cardiac in origin. I'm going to mention non-cardiac causes first because sometimes they can be easily missed or overlooked, leading to unnecessary intervention and medications. Treating the cause in most of the cases takes care of AF. COPD during its acute exacerbation is an independent risk factor for developing AF, especially in those patients who show P pulmonale on ECG. Hypoxia and hypercapnia are attributed to render atrial musculature prone to AF. Atrial fibrillation is also known to be associated with pulmonary embolism, which causes increased right atrium pressure, imparting stretch injury, which in turn may precipitate AF. Some studies have suggested atrial fibrillation itself as a risk factor for developing PE via a thromboembolic phenomena. Whatever the case may be, the relation of AF and PE should always be kept in mind. Coming to hyperthyroidism, AF occurs in up to 15% patients with hyperthyroidism and is attributed to shortening of action potential duration and also increased atrial pressures, secondary to increased ventricular mass. Cancer is another non-cardiac cause which should always be kept in mind. It has been attributed as a common cause of AF, so much so that some authors have suggested atrial fibrillation as a marker of occult CA in a younger age group, reasons for which are multifactorial. Raised CRP levels in chronic inflammatory diseases and acute infections such as pneumonia, etc., have been postulated to increase incidence of AF by rendering atrium susceptible to inflammatory product injuries. Electrolyte imbalance, especially hypokalemia, is one of the important reversible causes of AF. Patients with obstructive sleep apnea are also known to be predisposed to develop AF, which is attributed to increased left ventricular and atrial volumes in the long run. It is seen that use of CPAP in such patients reduces this predisposition by promoting cardiac remodeling. Glancing at the above factors, it is evident that we could encounter AF oftener than we think we would, and that AF can be precipitated in a variety of disorders, treatment of which would lower atrial fibrillation frequency in affected patients. We all are well aware of the cardiac causes of AF, which are cardiothoracic surgery, congenital heart disease, heart failure, infiltrative heart disease, myocardial ischemia, long-standing hypertension, pericarditis, valvular heart disease, and WPW syndrome. These diseases either irritate, inflame, deprive atrial musculature of blood causing ischemia, causes stretch injury, impart structural changes, or alter refractory period of atrium. Some of these causes are bidirectional in nature, starting a vicious cycle of self-feeding like MI, heart failure, etc. For not yet fully known mechanisms, post-cardiothoracic operative incidence of AF is as high as 30 to 55% depending on the type of the surgery patient has undergone. The incidence of AF in congenital heart disease is small but significant. Any congenital heart disease causing increased atrial pressure may predispose to AF. The most notable cause of AF is valvular heart disease, and standing out amongst all is mitral stenosis secondary to rheumatic heart disease. Patients with this condition have 17 times increased risk of developing stroke following AF, which is secondary to atrial overload and stretching consequent upon mitral stenosis. AF in the setting of Wolff-Parkinson-White syndrome is an emergency, as the antegrade conduction of atrial impulses via accessory pathway can result in excessive ventricular rate, which may precipitate ventricular fibrillation. Chances of developing AF in patients with accessory pathways varies between 10 to 40%. Coming to complications, we have already discussed this at various point of time earlier in the presentation. Just to recap, a patient with AF has 5 times higher chances of having a stroke than general population. AF due to RHD increases this chance to 17 times. AF from any other cause can also precipitate chronic cardiac failure if left untreated. We have seen stroke as a major outcome of AF. CHADS-2 and CHADS-2 VASCs are the risk stratification tools which are developed to assess likelihood of developing a stroke within 1 year of AF. They also guide a physician the type of therapeutic intervention that may be required. Both the scores are popular among physicians. CHADS-2 is better in predicting the high-risk group, while the newer CHADS-2 VASC is better at predicting the low-risk group. Understanding patients' disposition to certain conditions helps us in better management of case and even averting untoward incidences at times. Once a suspicion of AF has risen and clues have been obtained from detailed history of the patient, specific investigations should be advised to ascertain the cause of AF. I am here giving a comprehensive list of basic investigations which may be required in a patient of AF and is by no means exhaustive in nature. CBC will rule out infections, anemia, LFT, KFT, electrolytes, D-dimer, TSH, BNP, troponin, ECG, which is very important, which will confirm atrial fibrillation, echo, which will tell us about the heart size, shape, the wall kinetic, systolic and diastolic functions. Transesophageal echocardiography is another important investigation which would pick up clots which are not otherwise seen on echocardiography. Holter monitoring will reveal the paroxysmal nature of AF and will help in revealing triggering factors. Investigations such as EPS can be both of diagnostic value and may identify pathways suitable for ablation therapy. In the end, to sum up and conclude, we should keep AF in our minds as a differential diagnosis, even in an asymptomatic patient, especially elderly and those who have other comorbidities. After deciphering the type of AF, an active search for cause should be sought, as many of these are reversible in nature and can save unnecessary inconvenience to both physician and patients and help a person live a better life. Thank you.